Rheumatology and neurology are interconnected through several conditions that involve both the immune and nervous systems. This link arises because autoimmune and inflammatory diseases in rheumatology can often affect the central or peripheral nervous system, leading to neurological complications. Here are some key areas where the two fields overlap. 1. Neuroinflammation in autoimmune diseases. Autoimmune diseases like systemic lupus erythematosus, SLE, and Sjogren's syndrome can cause neuroinflammation, affecting the brain and peripheral nerves. Lupus, for example, may result in neuropsychiatric symptoms like seizures, cognitive dysfunction, or mood disorders. 2. Neuropathies in rheumatologic conditions. Conditions such as rheumatoid arthritis, RA, and vasculitis can involve peripheral neuropathy, where nerves outside the brain and spinal cord become damaged, leading to symptoms like numbness, tingling, or pain. Vasculitis can cause mononeuritis multiplex, a form of neuropathy where multiple nerves in different areas of the body are affected. 3. Fibromyalgia. This chronic pain syndrome, which is often managed by rheumatologists, has a strong neurological component, as it involves central sensitization, where the brain and spinal cord process pain abnormally, leading to widespread pain and fatigue. 4. Multiple sclerosis and autoimmune disorders. Multiple sclerosis, MS, a primary neurological disease, shares common autoimmune mechanisms with rheumatologic conditions. For example, patients with Sjogren's syndrome or lupus may have an increased risk of developing MS or other demyelinating disorders. 5. Myopathies and neuromuscular diseases. Autoimmune myopathies, such as polymyositis and dermatomyositis, can lead to muscle weakness and may have neurological symptoms due to muscle and nerve involvement. 6. Central nervous system, CNS involvement in vasculitis. In conditions like giant cell arteritis and Behçet's disease, inflammation of blood vessels can lead to CNS involvement, potentially causing headaches, strokes, or other neurological deficits. 7. Neurological side effects of rheumatologic medications. Drugs used to treat rheumatologic diseases, such as steroids, biologics, and immunosuppressants, may have neurological side effects, including mood changes, cognitive dysfunction, or peripheral neuropathies. In summary, rheumatology and neurology often intersect due to the immune system's role in both joint and nervous system diseases. Collaborative care between rheumatologists and neurologists is sometimes necessary to manage patients with overlapping conditions. Neurological complications in rheumatic diseases are common and can affect both the central nervous system, CNS, and peripheral nervous system, PNS. These complications arise due to autoimmune processes, inflammation, and vasculitis, which impact the nervous system in different ways. Below are some of the key neurological complications associated with various rheumatic diseases. Sure. 1. Systemic lupus erythematosus, SLE. Neuropsychiatric lupus, NPSLE, a broad term for CNS and PNS involvement in lupus, affecting up to 40 to 60% of patients. CNS complications, cognitive dysfunction, headaches, seizures, psychosis, mood disorders, cerebrovascular disease, strokes, and demyelination. PNS complications, peripheral neuropathy, cranial neuropathies, and autonomic dysfunction. 2. Rheumatoid arthritis, RA. Peripheral neuropathy, inflammation of the joints can compress nearby nerves, e.g. carpal tunnel syndrome. Small and large fiber neuropathies can also occur, causing pain, numbness, and tingling. Cervical myelopathy, atlantoaxial subluxation in the cervical spine due to joint erosion, can lead to spinal cord compression, causing weakness, numbness, and sometimes paralysis. NASH 3, Sjogren's syndrome, peripheral neuropathy, involves small fiber neuropathy, pain, burning sensations, sensory neuropathy, or sensory ataxic neuropathy. Cranial nerve involvement can cause trigeminal neuralgia. CNS complications, cognitive dysfunction, and in rare cases, multiple sclerosis-like symptoms. MAR4, vasculitis, systemic and CNS vasculitis. Mononeuritis multiplex. Multiple peripheral nerves are damaged, leading to pain, weakness, and loss of function in affected limbs. Central nervous system involvement. Stroke-like symptoms due to inflammation of the blood vessels supplying the brain, e.g. in giant cell arteritis or polyarteritis nodosa. Cerebral vasculitis can cause headaches, cognitive dysfunction, seizures, and even strokes. Hammer 5, Behçet's disease, Neurological neurobatiates, involve both the CS and PNS, leading to meningoencephalitis, stroke, brainstem syndromes, and cranial neuropathies. Peripheral neuropathy, less common but can also occur. Multiple sclerosis, MS, like syndromes, rheumatic diseases, particularly Sjogren's syndrome and antiphospholipid syndrome, APS, may mimic MS due to demyelinating lesions in the CNS. Symptoms include weakness, visual disturbances, and motor difficulties. 7. Antiphospholipid syndrome, strokes, and transient ischemic attacks. APS can lead to clot formation in the brain, causing strokes, TIAs, and cognitive dysfunction, often referred to as antiphospholipid antibody-associated cognitive dysfunction. Chorea, a rare movement disorder seen in APS, characterized by involuntary jerky movements. 8. Systemic sclerosis, scleroderma. Trigeminal neuralgia, facial pain due to trigeminal nerve involvement. Peripheral neuropathy, mostly related to vascular changes or secondary to compression syndromes, e.g., carpal tunnel syndrome. 9. Ankylosing spondylitis, cauda equina syndrome. In severe or advanced cases, spinal inflammation can compress the nerve roots at the lower end of the spinal cord, leading to bladder dysfunction, leg weakness, and sensory loss. 10. Fibromyalgia. While not classically associated with structural nervous system damage, fibromyalgia is linked to central sensitization, where the CNS becomes hypersensitive to pain signals, causing widespread pain, cognitive dysfunction, fibrofog, and fatigue. 11. Mixed connective tissue disease, MCTD, can lead to CNS manifestations like seizures, headaches, or cognitive dysfunction, and PNS issues such as peripheral neuropathy. 12. Polymyositis and dermatomyositis. While primarily muscle diseases, they can involve neuromuscular junctions, causing profound muscle weakness, and in rare cases, dysphagia or respiratory muscle involvement that may impact nerve function indirectly. 13. Infections in immunosuppressed patients. Patients with rheumatic diseases often receive immunosuppressive therapies, which increase the risk of infections like meningitis or encephalitis that can cause neurological symptoms. Conclusion. Neurological complications in rheumatic diseases are diverse, affecting both the central and peripheral nervous systems. Early recognition and multidisciplinary management by rheumatologists and neurologists are essential for preventing permanent damage and optimizing outcomes. Neurological diseases can sometimes lead to rheumatic complications due to shared immune mechanisms, side effects of medications, or secondary consequences of neurological dysfunction. Here are some key rheumatic complications that can arise in association with neurological diseases. 1. Multiple sclerosis. MS-associated arthropathy. Joint pain and stiffness can occur in MS patients, possibly due to altered biomechanics from muscle weakness or spasticity. Osteoporosis. Immobilization or long-term use of corticosteroids in MS can increase the risk of osteoporosis and fractures. Chronic pain and fibromyalgia. Some MS patients develop fibromyalgia, a condition characterized by widespread musculoskeletal pain, fatigue, and tender points, likely due to central sensitization mechanisms. 2. Parkinson's disease. Frozen shoulder adhesive capsulitis. Common in Parkinson's disease, where joint stiffness and pain, particularly in the shoulders, may develop due to decreased mobility and muscle rigidity. Arthritis. Degenerative joint disease, osteoarthritis, is more common in Parkinson's patients, especially in the spine and large joints, likely due to abnormal posture and decreased mobility. Gout. The use of diuretics, often prescribed in Parkinson's disease for controlling symptoms, can increase the risk of hyperuricemia and gout. 3. Stroke, shoulder-hand syndrome, complex regional pain syndrome type 1. After a stroke, patients may develop severe pain, swelling, and stiffness in the affected limb, particularly the shoulder and hand. Post-stroke arthritis and joint contractures. Immobility following a stroke can lead to secondary joint stiffness, contractures, and even arthritic changes due to disuse or abnormal positioning. Osteoporosis, prolonged immobility, increases the risk of bone loss and fractures on the paralyzed side. Hack 4. Peripheral neuropathies. Charcot joint, neuropathic arthropathy. In diseases that cause severe peripheral neuropathy, e.g., diabetes, leprosy, or syringomyelia, patients may develop Charcot joints, where joint destruction occurs due to loss of protective sensation. This is most common in weight bearing joints like the feet. Muscle wasting and contractures. Peripheral neuropathies can lead to muscle atrophy and joint contractures, leading to secondary joint pain and stiffness. NAR 5. Epilepsy, osteoporosis, and fractures. Long term use of anti epileptic drugs, especially those affecting vitamin D metabolism like phenytoin or carbamazepine, increases the risk of osteoporosis, leading to higher fracture risk. Gout. Some anti epileptic drugs, particularly diuretics or those affecting renal function, may increase the risk of gout. 6. Neuromuscular diseases, e.g., myasthenia gravis, ALS, muscle weakness and joint instability. Weakness in muscles around joints can lead to joint instability, overuse injuries, and secondary osteoarthritis. Contractures. In advanced stages of neuromuscular diseases, patients can develop joint contractures due to chronic immobility or spasticity. 7. Cerebral palsy, hip dysplasia, and degenerative joint disease. Patients with cerebral palsy often have hip dysplasia and early onset arthritis due to altered gait and joint mechanics. Spinal deformities, scoliosis. Common in cerebral palsy, these can lead to secondary musculoskeletal pain and functional limitations. Osteoporosis. Decreased weight bearing activities can lead to osteoporosis, particularly in patients who are wheelchair bound. 8. Spinal cord injury, heterotopic ossification. This is the abnormal formation of bone in soft tissues around joints, most commonly in the hips, following spinal cord injury, leading to joint stiffness and pain. Osteoarthritis. Changes in joint mechanics and prolonged immobility increase the risk of developing degenerative joint disease, particularly in the shoulders and hips. Osteoporosis and fractures. Immobilization increases the risk of bone loss, especially below the level of the injury. 9. Migraine and headache disorders. Fibromyalgia. Chronic headache disorders are associated with fibromyalgia, a rheumatic condition marked by widespread pain, tender points, and fatigue. Central sensitization mechanisms may link the two conditions. 10. Chronic neuropathic pain. Fibromyalgia and myofascial pain syndrome. Patients with chronic neuropathic pain conditions, such as complex regional pain syndrome, CRPS, or postherpetic neuralgia, may develop fibromyalgia or myofascial pain syndrome, where chronic pain leads to widespread musculoskeletal pain, muscle tenderness, and fatigue. 11. Neurological medication-induced rheumatic complications. Steroid-induced myopathy and osteoporosis. Long-term use of corticosteroids for neurological conditions like multiple sclerosis or myasthenia gravis can lead to muscle weakness, osteoporosis, and a vascular necrosis of the bone. Drug-induced lupus. Certain medications used in neurology, such as anti-seizure drugs, e.g., phenytoin or biologics, can induce lupus-like syndromes, leading to joint pain, rashes, and other systemic symptoms. Conclusion. Neurological diseases can lead to several rheumatic complications, including joint disorders, osteoporosis, muscle atrophy, and secondary pain syndromes. Understanding the link between these two fields is essential for providing comprehensive care, as managing both neurological and rheumatic symptoms often requires a multidisciplinary approach. Rheumatologists and neurologists often collaborate when diseases have overlapping features affecting both the immune and nervous systems. Knowing when to refer a patient to the other specialty is crucial for optimal diagnosis and treatment. Below are key scenarios where cross-referrals are necessary. When a rheumatologist should refer to a neurologist. 1. Suspected central nervous system involvement. Neuropsychiatric symptoms. In conditions like systemic lupus erythematosus, SLE, Sjogren's syndrome, or vasculitis, when patients develop cognitive dysfunction, seizures, psychosis, or stroke-like symptoms. Multiple sclerosis-like symptoms, when a patient with autoimmune disease presents with visual disturbances, motor deficits, or paresthesias resembling MS. Headaches, persistent unexplained headaches in conditions like giant cell arteritis or Behçet's disease that may indicate CNS vasculitis or other neurological involvement. 2. Peripheral nervous system involvement, peripheral neuropathy. In diseases like rheumatoid arthritis, Sjogren's syndrome, or vasculitis, when patients present with unexplained numbness, tingling, or weakness indicating nerve involvement. Mononeuritis multiplex. In conditions like vasculitis, e.g., polyarteritis nodosa or Churg-Strauss syndrome, when there's asymmetric weakness or sensory loss due to multiple nerve involvement. Cranial neuropathies. In cases where cranial nerve palsies occur, such as Bell's palsy or trigeminal neuralgia in Sjogren's syndrome. 3. Muscle weakness and neuromuscular disorders. Suspected myositis or neuromuscular junction disorders. When patients present with muscle weakness that could be due to polymyositis, dermatomyositis, or myasthenia gravis. Unexplained muscle weakness. If a patient with a rheumatic disease develops sudden, severe weakness, or if weakness is out of proportion to the degree of arthritis. 4. Cervical myelopathy and rheumatoid arthritis. In patients with rheumatoid arthritis and neck pain or neurological symptoms, e.g., weakness, numbness, refer to evaluate for atlantoaxial subluxation or spinal cord compression. 5. Complex regional pain syndrome, CRPS. In cases where patients with autoimmune diseases or post-surgical outcomes develop severe localized pain, swelling, and autonomic changes, indicating CRPS. When a neurologist should refer to a rheumatologist. 1. Suspected autoimmune or inflammatory disorders. Neuropsychiatric lupus. When a neurologist diagnoses or suspects lupus-related cognitive dysfunction, seizures, or psychiatric symptoms. CNS vasculitis, in cases of unexplained strokes, seizures, or cognitive decline where there is suspicion of vasculitis affecting the brain, e.g. in giant cell arteritis, Takayasu's arteritis, or primary CNS vasculitis. Antiphospholipid syndrome, APS, when a patient presents with unexplained strokes, TIAs, or thrombosis, and APS is suspected. 2. Chronic pain and fibromyalgia. When a neurologist encounters a patient with widespread pain, fatigue, and multiple tender points without clear neurological causes, fibromyalgia should be considered, and a referral to a rheumatologist for diagnosis and management is needed. Chronic neuropathic pain syndromes. When pain is not explained by clear neurological pathology, and there is suspicion of a rheumatic pain syndrome, e.g., myofascial pain syndrome, fibromyalgia. 3. Neurological manifestations of rheumatic diseases, peripheral neuropathy. When neuropathy is present and there is suspicion of an underlying autoimmune condition, such as Sjogren's syndrome, rheumatoid arthritis, or vasculitis. CNS demyelination. If a patient shows MS-like demyelinating lesions and there is suspicion of a systemic autoimmune disease, e.g., Sjogren's syndrome, lupus, a referral to a rheumatologist is appropriate for systemic evaluation. 4. Muscle weakness and myositis. Polymyositis or dermatomyositis. When a patient presents with proximal muscle weakness or elevated muscle enzymes and there is suspicion of autoimmune myopathy, a referral to a rheumatologist is warranted. 5. Giant cell arteritis, GCA. If a neurologist encounters a patient over 50 years old with new onset headaches, vision changes, or stroke-like symptoms, GCA should be considered, and an urgent referral to a rheumatologist is necessary for temporal artery biopsy and treatment to prevent complications like blindness. 6. Systemic autoimmune diseases with neurological symptoms. If the patient has neurological symptoms and features suggestive of systemic diseases like scleroderma, systemic lupus erythematosus, SLE, or mixed connective tissue disease, MCTD, a referral to a rheumatologist should be made. Summary of key referral indicators. Rheumatologist to neurologist. When neurological symptoms, e.g., neuropathy, cognitive changes, seizures, strokes, emerge in the context of rheumatic diseases. Neurologist to rheumatologist, when systemic autoimmune diseases, e.g., lupus, vasculitis, Sjogren's, or rheumatic pain syndromes, e.g., fibromyalgia, are suspected in patients with neurological symptoms. Collaboration between these two specialties ensures that complex autoimmune and neurological conditions are accurately diagnosed and managed.